Good morning. We're going to get started with GU. So let me flip over on our screens and share. And let's see what we can get going for you. And we're still recording. And Miss Elizabeth, we're going to put you in presentation mode.
There we go.
And,
All right.
oops.
Are we going to switch chairs?
No, I'm just
Oh,
going
we're going to do this. Well, then let me get my stuff out of the way. Hi, guys.
Do you want to come to this chair?
Nope,
I'm
we're
going
good.
over here. I'm going over
then
here.
let
So
me
you
come
sit
here.
wherever you want.
Okay. Good morning, everybody. I'll get in the screens in a minute. We've had technical difficulties. Imagine that. Technical difficulties. I hope everybody is doing well. I am on day, let's see, tomorrow will be the 23rd. That was my last day to work officially. I've worked 7 half days since then, so yay me. But I hope everybody is doing well, staying safe. Dr. Blankenship and I were talking this morning. I'm about to the point of being exposed to COVID, so I can have it and have immunity, and we can move on. But that's just me talking, because I'm a little frustrated, and I know you all are too. And this is not the way to have school, at least for me. I don't do it this way. Never have done it this way, but some of you it may work for. So we're going to start today with GU disorders, genital urinary disorders in children. So, and Dr. Blankenship is going to, if she has not, the guidelines for UTI from the AAP. It's from the Pediatrics, September 2011, volume 128, issue 3. And it is 35 pages long if you print it out. It's huge. I'm going to be honest with you, I have not gone online to see if they have been reaffirmed, but in practice, nothing has changed. And I also hear that you had an issue in one of your test questions with your AOM guidelines versus what was in the book. So that's a real dilemma. So always, I'm just going to tell you, books are already outdated by the time that they get published, even if they're a frequent edition. So always go with your guidelines, because that's the industry standard. And so, so we'll see with this. And urinary tract stuff is even more important in children. So let's get started as we talk about it. As you know, I always start with a little anatomy. So we talk about development. Now, if you remember previously, when we talked about ears, that they develop, the hearing and the ears and all of that develops in utero starting about 3 weeks and finishes developing it at 3 months. And I talked at the same time that if you have an ear anomaly at birth, then you need to check the kidneys, because kidneys form in the utero at the same time ears do. And this says about 9 weeks gestation. But that's that 3 months. So there's an occasional association, as we've talked about, between ear anomalies and renal anomalies. And a good NICU or a good neonatologist or a pediatrician who have ever seen that baby in the nursery should, if there's an ear tag or any kind of other ear anomalies, they should go ahead and have renal studies done. And that can include, as in bullet point number 2, like pits, tags, malformed ears. We've got to assess that kidney dysfunction and development. So even though they start developing at 3 weeks of gestation and they progress, of course, just like hearing and ears do, through several stages before we have glomerular filtration at 9 to 10 weeks of age, okay? So you've got lots of pee when babies are born, and it's not necessarily filtered much through the kidneys initially, okay? So now, when we talk about doing a renal assessment or just a general assessment, we talk about looking for those ears, low set ears, any anomalies, failure to thrive. If you've got this baby that seems to be eating well, just not gaining weight, kidney assessments or renal assessment or GU is one of the things you're going to look for. Blood pressure. Now, in a baby, it's really hard to get a blood pressure. We don't even have, I don't even know if we've got an infant cuff in our department. If we do, we rarely use it. However, if it's in the nursery, if they're suspecting something, they're able to do that. In our older kids, we start doing routine blood pressures at 3 years of age. So blood pressure can be one of those things. Just like with adults and kidneys, blood pressure is affected by kidney function. So, and of course, looking for edema, pallor, dehydration. You also want to look for any external genitalia. I can't talk this morning. It is early. We're here early Wednesday morning. External genitalia abnormalities. And what would that be? And we're going to talk about some of those as we go along, such as enlarged clitoris and other things, hypospadias, and like I said, we're going to get into that. And then some of your unusual facial features associated with renal anomalies. So knowing some of those can be very beneficial. Okay. Old CART. Do you see my acronym there? Assessing for illness. How many of you know this already? So when we're assessing for illness, and this can be for anything, using old CART, your onset, when did it start, location. So is it low in the bladder? Are we having left or right abdominal quadrant pain, flank pain, back pain, generalized abdominal pain? Is it a sudden pain? Is it constant? Is it variable? Some of the characteristics, are we having vomiting, fever? Is it dull versus sharp? Is there an abnormal color to the urine? Any odor? Any pain when we go potty? Is there frequency or urgency? So looking for those characteristics. Any aggravating factors? Does anything make the pain or discomfort worse? Are they teenagers or young adolescents? Unfortunately, we're seeing them younger and younger and younger becoming sexually active. So you got to ask those questions, and that's a hard question to ask when you've got a parent sitting there. And if it makes you feel better, because some of these kids are not going to answer you honestly, and we're going to talk more about that when we do GYN. Sometimes you got to get that parent out of the room, especially if you suspect that it's maybe an STD. Then you've got to ask those kids, and you've got to tell them that it's really important that they've got to be honest with you, because if they're sexually active, you've got to know it, so you know how to appropriately move forward. And sometimes you move forward even if they're denying it, because you've got to rule that out. So we'll talk about that more with GYN. So the R is relieving factors. Does anything make the discomfort better? And then treatment. What was done to treat the pain? Meds, warm baths. Have you given them azo, cranberry juice, blah, 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 blah. Azo, of course, as you know, can screw with a urinalysis. So if they've had azo, it's really important, because you're not going to get an accurate urinalysis. So if they've had azo, they need to go off of it, flush really good, and then you need to do your analysis maybe in 24 hours. So now let's talk about UTIs in kids. I think this is one of the biggest pet peeves with nurse practitioners and physicians alike who don't see kids on a regular basis. Because anytime with some providers, anytime they see leukocytes in a urinalysis, they assume UTI and start treatment. That's not a good thing. That is not a UTI, because kids can have leukocytes in their urine for lots of different reasons. I've seen kids have leukocytes in their urine because they had strep throat. So, so what we're going to talk about UTI today, as far as GYN, is probably one of the most important things I'm going to talk about in any of the lectures today, because they're so often overdiagnosed and diagnosed incorrectly. Now, it is the most common cause of a serious bacterial infection in under 2 years of age, with fever without a focus. So if you've got a kid under 2 that comes in and they've got a fever and they chest x-ray is normal and their CBC is maybe showing a elevated white count, but their physical exam is absolutely benign, one of the first things you've got to do is you've got to get a urine. And most of the time, this is going to be a cath urine, because if you get a U bag and you have growth, it could be a contaminant. So you've got to bring them back and do a cath. So why deal with twice when this is not getting treated if they really need to be treated? Okay. I hope everybody understands what I'm talking about there. Does that make sense, Dr. Blankenship? She's shaking her head. Yes. Okay. So a lot of parents don't like to do that, and they don't want to have that cath done because they know it's traumatic. However, if you've done everything else and you feel like this is probably a urinary tract infection, then you just really need to say, we need to know if this is a urinary tract infection, and this is the best way. And then you explain to them, if we do the U-bag and we get a contaminant or we get a positive growth, then they're going to have to come back in and be cathed anyway. So you've got this parent who's got this kid with a fever, and they don't feel good, and they can't tell them what's going on. And so a lot of times, if you've done everything else and done your homework and done your workup, then you can talk them into this. And I don't know about it anywhere else, but our LPNs do this on a fairly regular basis, and they're pretty darn good at doing an in and out sterile cath on our kids. So, and then we know for sure. Okay. So with urinary tract infections, sometimes we'll have some asymptomatic bacteriuria. And we've had kids and preschoolers come in and get a urine done. Now, the older they are, you can get the clean catch. If they're potty trained and can do that, and that works really well. Sometimes they won't be symptomatic at all, but they will have a urine that grows out like greater than 100,000 on E. coli. So we have to treat that. So that's your asymptomatic bacteriuria. Sometimes they'll have cystitis. Oh my gosh. They'll be burning and complaining of pain, and the urine is fairly clear, but they are in significant discomfort. So we usually will treat that. And then of course, pyelonephritis. And that can be pretty intense. I wanted to swipe. This is not a swipe, is it? I'm used to my iPad. Sorry, guys. All right. So as we've already talked about, asymptomatic bacteriuria is bacteria in the urine without other symptoms. Sometimes it can be benign. Sometimes it's not. Again, that's that 25 to 50 to 100 leukocytes in the urine, and it grows out nothing. It doesn't cause any renal injury. And a lot of times this is associated with school age and older girls just because. And if the guys in this class may not understand that, but most of the women are going to, just because of life, because everything is just too close down there to itself. So what are we going to do? As we talked about assessment and treatment, your analysis may show leukocytes in the urine. Always get a urine culture. Now they may have 500,000 or 500 plus leukocytes in their urinalysis, and their nitrites might be positive, and it looks, and they've got bacteria and blah, 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 blah. So you may highly suspect a urinary tract infection, but you still need to get a urine culture. Okay, because we need to know what organism we're treating, and if the medicine that we're going to put them on is going to be effective. Because there's times we've been treating a urinary tract infection, and we do come back with a microorganism that's growing greater than 100,000 colonies per high-powered field, but it's resistant to what we've put them on. Okay, but in case of asymptomatic bacteriuria, there's no treatment needed, as we've already talked about. If there's a urine culture, no growth in 24 and 48 hours. Even if there's urgency, dysuria, and frequency, we don't treat on pyuria alone without a positive culture unless you've got other clinical signs. And then that's going to be a clinical diagnosis, but it's not a UTI. Okay. Other reasons likely for leukocytes, as we've already talked about, like strep throat, viral disorders, sometimes chemical irritation. And soapy water, that's one of the first things you need to ask about, especially for little girls. Are they sitting in bubble baths, or are they sitting in, they've had their bath and they've had their hair washed, but they're sitting in the tub to play in that soapy water afterwards? This can cause, soap decreases the surface tension of the water, and it allows irritation up into the urinary tract. So hot tubs can be another source, as we all know. They can be a source of all kinds of wonderful stuff. And bleaching their underclothing can also cause irritation. That was me growing up. Of course, now leggings are so popular, especially with little girls. So tight underclothing and pants can be an issue, especially if the kids are overweight and those are really tight and their legs rub together and there's just not a whole lot of air moving, so that stays warm and wet in that area. Also, poor hygiene. Kids still need supervision, at least to make sure that they have cleaned well, rinsed well, and even though you're not wiping their bottoms, they still need monitoring, especially through toilet training and afterward. And then also, one of the other huge things we see is constipation causing leukocytes and belly pain, and can be very much mirror a UTI. And also, of course, diarrhea. And if you've got diarrhea, then especially in little girls, there's the potential for cross-contamination. Okay. Cystitis. Now, it's an infection of the bladder that causes lower urinary tract symptoms. And so you may have that vaginal erythema, edema, irritation. They may cry when they go pee, especially in kids that aren't speaking yet, especially if they're still in a diaper. Especially potty training is a huge time for this. Through preschool, they're not wanting to go because it hurts, so they hold it, and then they're screaming in pain. So the first thing a mom thinks of is that they've got a urinary tract infection. And we do a lot of urines that come back negative with this scenario. So those are your most common organisms listed there. E. coli is one of our biggest, Klebsiella, Pseudomonas, Proteus, Group B strep, and occasional Group A strep. So we're going to treat that. And we're going to talk about treatments in a little bit. So pyelonephritis is, of course, our most severe type of UTI. And if you've had adult stuff so far in your, I don't know where PEDS falls in your NP curriculum, but pyelo is pretty intense. It can cause irreversible renal damage. You know that. Signs and symptoms: ill appearing, fever. Their blood pressure may be elevated. You're going to have abdominal pain or palpitation. You may have some vaginal erythema, edema, irritation. They may have a discharge. In your males, you may have some urethral changes. They may have a weak stream, or even girls too, and dribbling. They may have CVA tenderness, and you all know how to do that. You should know how to check for CVA tenderness, or they may have flank pain. So it's going to be really important. Here it is. This is one you're looking for. Sorry. This is really important. So if we've got a 2-month to 24-month, our pyuria, you may have 10 white blood cells per high powered field on a UA, and to actually diagnose a UTI, you've got to have greater, and this is in the guidelines, greater than 50,000 colonies per milliliter or per high powered field of a single antigen in appropriately collected specimen of urine. So a cath or a suprapubic cath, we don't do those very often. You may in a hospital situation, but you're not going to do that in a primary care office. So cath or a good clean catch, at 24 months of age, most of the time they're not potty trained well enough to do that. Okay. So depending on what our organism is, we're going to do 7 to 14 days of an appropriate antibiotic. We're going to do close monitoring with follow-up urinalysis at the end. Actually, we're going to culture it. Depending on their age, if this is a little thing, if this is a baby, we're going to do renal and bladder ultrasounds. If it's one of my youngest patients, that had a UTI, was less than 2 months old because the baby came in with a fever. And if you've got a neonate with a fever, and this was a fever of 102 plus rectally, you've got to figure out, first thing you think of is septic, okay? But if everything else pans out, then you've got to do a cath, and you suspect a urinary tract infection, and it was. And I sent them immediately on to Lexington because this is when I was in Eastern Kentucky. After calling urology, they went straight in, and this particular child ended up having a grade 4 urinary reflux because so if we detect in the bladder and renal ultrasounds, if the anomaly is detected, they're going to do a voiding cystourethrogram. We don't do those if the ultrasound is normal, okay? VCU should be done if recurrent for febrile UTI. So, and like I said, depends on the age. If they're 4 or 5 and they're a little girl before they have a UTI, you might not necessarily do that because especially if your microorganism isn't E. coli, because it's just from cross-contamination, most likely. But in our little ones, they're probably going to do that initially on first UTI, okay? So just something to think about. U-bags are great, but they also have a false positive result 88% of the time, and it's usually from contamination. And I've gotten to where I put my own U-bags on because I don't trust but either parents or my staff to clean them like I do, because especially with little girls, it's really hard because you've got to get that U-bag stuck between the vaginal opening and the rectal opening. And so it's collected, and you've got to make sure that you've cleaned really good. So as I told you earlier, if they're positive on a U-bag, then you're going to need to cath them anyway to verify. So start out with a cath. Now, we do U-bags as our screening tool on our 9-monthers just to assess for kidney function. And we've gotten some what we call asymptomatic bacteria in those kids, and they've had to come back and be cathed, which is traumatic on the kid and the parent, but then they've turned out to be nothing. And then we've turned out to have some kids that were actually growing microorganisms on the cath specimen, and they weren't having any fever or doing anything else. So those are ways that we catch that. If we've missed a UTI, it could lead to renal scarring, and we don't want that to happen, especially in kiddos. But if overtreated, then we're exposing them to antibiotics when they're not needed. So it's a catch-22. So stick with your guidelines on this. And Nan Gaylord in your book from the 6th edition, wrote this chapter, and she's an amazing lady. But I haven't gone through to make sure that the chapter agrees with the guidelines. So, but if I know Nan well enough, which I think I do, that's it. So, as we talked about earlier, nitrite test is not necessarily a sensitive marker for children, but it is significant if it is positive. So they may have a UTI without positive nitrites, but they also may have positive nitrites and not have a UTI. Well, no, it's significant if it's positive, but they will have a UTI without nitrites sometimes. And I keep saying this, white blood cells in the urine does not mean a UTI. And all your antimicrobials should be chosen based on your sensitivities, medication, allergy history, and previous antibiotic use. And I say that, but we have things that we use. So according to your guidelines, your first line treatment is amoxiclav. Okay, you're going to dose it at 20 to 40 mg per kg per day. This says 3 doses, but you can do it in 2 doses. Compliance is really poor if you do 3 doses. What we start with most of the time, because so many of the times it is E. coli, we start with sulfamethoxazole trimethoprim, also known as Bactrim. Now, it's really interesting trying to figure liquid Bactrim. So according to Lexicomp and probably the guidelines, trimethoprim, you need to dose it at 6 to 12 mg per kg per day in 2 divided doses. And your sulfamethoxazole part is 30 to 60 milligrams per kg per day in 2 divided doses. Now, go for it. Go try to figure that. I'm going to give you the way that my NP teacher, my PNP teacher, taught me to do it. And it's here in your notes. Their weight in pounds divided by 22 times 5. So let's say you have a 20-pound child. And, okay. You have a 20-pound child. I got my phone here. So we got a 20-pound child. We're going to divide that by 22. And you should get 0.909, blah, 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 blah. Because it's 200 per 5. So we're going to times that by 5. And that's going to give you 4.54 milliliters per dose. Okay? That's on a 20-pound child. That sounds like a whole lot. So when you get an older child, let's say we have a 44-pound child. That's going to be 10 milliliters per dose. Okay? So when the more liquid you get per dose, sometimes compliance can be an issue. So, and if you want to do it the other way, if you want to do the, you can do it this way, 3 milligrams per kg per dose. Okay. So if you do 3, all right, let's do it again, per milligram per kg. So let's go back to our 20-pound kit. 20 divided by 22 is 0.900 times 3 is 2.7 milliliter. But that's the low end, okay? So if we did it at the 6, it's going to give you 5.45. So doing it the other way gives you a mid-range as well. So sometimes we can use a cephalosporin. Depends on which one. Usually Kelflex is not going to do it, or cephalexin. We usually have to use Ceftonir or Omnicef. But usually we try to stick, if there's not an allergy to penicillin or sulfa, we try to stick to the first 2. If we've got a really bad UTI, then we're going to give them a Rocephin shot. Now, this is higher, and this is in your guidelines. 75 milligrams per kilo in injection for 1 to 2 days, and then switch to oral. Usually we do it for 1 day, and then we switch to an oral med. I've not ever seen the docs that I work with go all the way up to 75 mg per kg. We usually stick with 50 because you can only give a maximum of 1 gram a day anyway. So some of the other things available are gent, tobramycin, piperacillin, acetoxamine. Nitrofurantoin is not appropriate for use in children unless they are resistant to everything else, and it's sensitive to that. Usually by that time, if they've had that many UTIs or issues, they're usually involved with pediatrology. And so I have done nitrofurantoin in kids. It's not my first love, but again, my little one that had her first UTI at less than 2 months of age, it got to the point that she was resistant to everything else, and we had to use nitrofurantoin. So that's where you work in conjunction with your pediatrology people. Okay, and we've talked about this, UTI in less than a 2-month-old. You suspect a UTI if the fever is over 100.4 rectally and they've got a normal exam, and then you're not going to wait for a urine culture. You're going to contact pediatrology. This is emergent. And again, a lot of times it's due, especially, it's usually a structural issue, like a reflux. All right, moving on. So let's talk about Wilms tumor. It's the most common genitourinary malignancy, 85% of all childhood renal cancers. And this usually hits kids in that 2 to 4 years of age range. It's very rare to be less than that or older than that. Sometimes, the biggest sign and symptom is you see the double stars there, smooth, firm mass in the abdomen or flank, and increasing abdominal size. They have fever, difficulty breathing, diarrhea, vomiting, weight loss, or malaise. That is pretty common signs and symptoms. Excuse me. Pollen. Oh. So some of the things you might see though along with it, and you need to suspect, is cryptorchidism, hypospadias, and right now I've got 3 or 4 babies that have been born in the last year that have issues with hypospadias. Some ambiguous genitalia, hemihypertrophy. I've got some sweet little girls that are dealing with hemihypertrophy, cardiac abnormalities, aniridia, which is they were born without an iris, which is interesting. And then, of course, they have duplication of the collecting system. So that's where your ultrasounds and your CTs are going to be significant. Okay, so when we talk about Beckwith-Wiedemann, some of these syndromes, I'm going to give you a little bit of info on that. Actually, mostly I'm going to give you more about the Wager syndrome, W-A-G-R. It is a disorder that affects many body systems, and it's named for its main features. Wilms tumor, so this is an anagram. Isn't that what that word is when everything, anagram? Aniridia, which we've talked about, genitourinary anomalies, and intellectual disability, usually referred to as mental retardation, but you all get the idea. Abnormalities of the genitalia and urinary tract are seen more frequently in males with Wager syndrome than in the affected females. The most common genitourinary anomaly in affected males is undescended testicles or cryptorchidism. Females may not have functional ovaries, instead have underdeveloped clumps of tissue called streak gonads. Females may also have a heart-shaped or a bicornate uterus, which makes it difficult to carry a pregnancy to term. Okay. Another common feature of Wager syndrome is intellectual disability. Affected individuals often have difficulty processing, learning, and properly responding to information. Some individuals with Wager syndrome also have psychiatric or behavioral problems, including depression, anxiety, ADD, OCD, or a developmental disorder with like autism that affects communication and social interaction. So that's interesting. So you kind of need to keep those kind of things on your radar when you're dealing with some of these kids and some of those kinds of things, and be cognizant that Wilms tumor could present with these kids. So you're going to do chest x-rays and abdomen x-rays, and this has to be differentiated between a neuroblastoma and a nephroblastoma. A neuroblastoma is calcified versus a nephroblastoma. A urinalysis, they can have blood in their urine, but kids can have blood in their urine for all kinds of reasons, and microhematuria can be a huge issue, and you beat your head against the wall and don't know what to do about it. And athletes, especially kids that are athletic, it's kind of a common thing. So, but microhematuria can be a huge issue if it's persistent. It's probably not in one of my slides. You probably need to have that checked out with urology just to make sure that there's nothing else going on. So besides a urinalysis and a CBC, you're going to do a reticulocyte count, and you're going to do a complete metabolic panel, including your liver and electrolyte studies. And if they deem that they're going to do a CT, and this is probably going to be beyond what you're going to do. Usually CTs are better approved through insurance, unfortunately, through the specialist. But you're going to do the rest of this stuff, and you're going to, if you get the x-rays and maybe even an ultrasound, and do all the rest of your homework, as we talked about last time, urology is going to be very, very appreciative, and they're going to be able to get on this much quicker. Hypospadias. This is really interesting, a condition in which the urethral meatus is not located in the right spot. And you have different types of those, and they're different places. They can be underneath or the bottom aspect of the penis, and they can range from just below the corona or the cleft of the penis to close to the anal opening. I mean, you just don't know. Babies with hypospadias should not be circumcised. Now, how do you know if they've got hypospadias and before you circumcise them? Well, whoever sees them in the nursery should be putting just enough pressure on that. They're doing construction here. I'm sure you can hear that in the background. That just started. I hope I can talk over it. They should be putting enough pressure easily on the foreskin to see if you can see the urethral opening at the top of the penis where it should be. Okay. The reason they should not be circumcised is because when they fix the hypospadias, they usually use the foreskin as the graft that they're going to use to fix it with. Okay. Now, this is an immediate referral to urology, and with surgical repair, there's a good prognosis, and it really depends. I've got one patient right now who's got a subcoronal hypospadias that goes up into, it's not completely off of the penile head, but it encompasses part of, but it's not in the right spot. And the urologist has told them that it's not causing him any problems, and it could affect his sexual abilities in the future, and he wouldn't do anything about it. Like, okay. Then we've got several others that they are in stages. They usually don't want to fix them till they're 3 to 6 months of age or older, as long as they're not causing any problems and they're not having urinary tract infections. So, but you're going to refer these babies if they have a hypospadias. And the interesting part is I've actually found some that weren't picked up in the nursery. So, interesting. So, anyway, hypospadias is interesting situation. Okay, there they are. There's your subcoronal. There's a midshaft, and then there's a penile scrotal. And there's others. Like I said, they can be further on down. They can also be ventral epispadias. So it opens on the top instead of underneath. So that presents a whole different issue as far as diapering. Boys are notorious for peeing in the front, whereas girls pee down into the diaper. But if you've got epispadias, you really have to be careful because they're going to soak the front of their diaper and up into their clothes a whole lot easier. So again, same kind of thing. These are going to be an immediate referral. And we think about these more in boys, but these conditions can also happen in females as well. A side story, when I was doing school nursing, I was brand new to working with kids. I had been a med-surg nurse. I was working in a small county, and it was the only nursing job available in the county. And we had this little girl that they had contacted us. Was coming into kindergarten. And she had been born without a urethral opening. And so they had surgically given her one. But it was not in the spot where it was supposed to be. It was actually at the bottom of the vaginal opening. And the mother knew how to catheter, and we had a catheter at school once a day. And so we had to have the kindergarten aide had to be trained specifically by the mom as to how to cath. And when the aide was out and I had to come in and catheter, I didn't know how to find it. I couldn't find it. It was bad. I did not, even though I was there during the training, I did not actually get to spend time looking at where it was and how to get to it. So that was bad, but just those kinds of things happen. So that's more in that kind of thing. So crypto, orchidism. Absence of palpable testes in the scrotal sac. Now, you can have retractile, which are out of the scrotum but can be manipulated back in, and then they stay there. But gliding, they're brought into the sac but returns to a high position. You can have ectopic, which lays outside the normal path of descent. And one of the docs I worked for in this last year has had a patient that had an ectopic testy, and it was very obvious because it stuck out, and you could push it and it would go back down into the testicle. But of course they were seeing urology, and they were waiting to see if it would fix itself. Now, ascended, or the definition of that is they were previously fully descended, but they've reascended and lies outside the scrotum. And then trapped is a testes that is dislocated after a hernia repair. And that's one of the things you also have to think about. But anytime you take a diaper off and you start, sometimes in these little ones, the testes decide they want to come up into the body. So you have to put pressure above and push them back down. That doesn't mean they're necessarily retractile or that you have cryptorchidism. It just is what it is. But you need to be palpating testicles. Okay, that's really important. Because usually they descend into the scrotal sac between 7 to 8 months gestation. So if you've got a preemie, you may have more problems with that. And then low birth weight babies and then twins can especially be an issue. Usually they will descend on their own within the first 3 months, but rarely after 6 months. And so these kids need to be referred to urology for further evaluations, because if they go up in the body and stay in the body, it can cause the death of the testes. So hydrocele, pretty common. We see that a lot, and it's painless scrotal swelling. It's fluid only in the scrotum, and it moves from the abdomen to the scrotum and back, and there's a potential of a hernia with that. Usually the testes are very shiny and edematous, like there's a fluid sac. They don't have a whole lot of rugae, and you look at it and it's like, oh my, that's a very large scrotum for a baby so small. Now, one of the things that they taught me back in the day is to transilluminate, to take your otoscope and turn your lights off as much as you can, and to get underneath the scrotum and put a light and to see if you see the testes or any other, like if you're looking for a hernia that is moved down into the scrotal sac. So I don't know if they teach that much anymore, if that's in this. I can be honest with you about transillumination. It's been helpful for me, but also any hydroceles that persist greater than a year, assume that they're going to be associated with a hernia, and those kids need to be referred for further evaluation. So there we are. We are infant hydrocele, and it's being transilluminated. Like I said, the better, the darker it is, the better you're going to see. So this one on the bottom did not transilluminate, so you've got a hernia going on. So this is not fluid. You've got something else going on in this scrotum. So moving on to inguinal hernia. Inguinal and scrotal swelling that includes abdominal contents, as we just saw. These should reduce easily, but these kids need to be referred to a surgeon or urologist as soon as this is found. It's much more common in males than females, because why do we want to refer them? Because we don't want this to become strangulated, okay? And that can happen at any point in time. Usually the commonality in males is 8 to 10 to 1. So, and usually your peak incidence is around 3 months of age. So that 2-month checkup and that 4-month checkup are really important, that you're looking at scrotums and you're palpating in the inguinal area. Most of the time it's bilaterally. If it happens on one side, it's usually more likely to happen on the right side versus the left. So what are you going to do? You're going to do some abdominal x-rays and you're going to ultrasound. You're going to monitor them very closely. We're going to educate those parents. We're nurses, right? So we're going to educate them on what to look for if they are becoming incarcerated. So the pain, erythema, vomiting, irritability, any abdominal distension, that is a immediate emergency. Either call 911 or get them straight to the ER. Direct hernias increase in incidence after 3 years of age and are usually acquired, not they're born with. So indirect hernias will push down into the inguinal canal. Direct hernias will push outward through a weakness point in the abdominal wall. So there's your difference. So, okay, so on this picture, you're seeing the different types of hernia. Epigastric, upper abdominal midline, and usually these midlines are usually because the fascia doesn't cover. You've heard of diaphragmatic or abdominal hernias. That's what I consider that. There's an incisional hernia if they've ever had any kind of surgical procedure. Your direct hernia, as it says, is near the opening of the inguinal canal. And umbilical hernias, we see a lot of those. Especially in dark-skinned African-American descent children are much more common to have an umbilical hernia. I don't know the whys of that, but that just seems what I have seen over the last 15 years. And then your femoral occur in the femoral canal, and then your indirect inguinal at the opening of the inguinal canal. And this was where our one recently that was born, it was up in the inguinal canal, and the urologist said, we're just going to watch it, and we're going to make sure that it progresses and moves down into the scrotum. So there was no immediate surgical, but you cannot not refer these kids. So then we come to another issue is testicular masses, and these are often a malignancy. Any mass on a testicle should be suspicious, any mass. And we've got to teach our teenagers that because, testicular cancer is a young adult disorder or a condition. And so we need to, we teach, I'll get it out, breast, what do you call it? Thank you, breast self-exam. So when I've got my teenage boys in the room, I guess maybe because I've raised boys and I've been around, it doesn't bother me, but they get really bent out of shape with it, embarrassed. But we talk about self-testicular exam and how important that is. And I tell them when to do it and where to do it, like in the shower under warm water about once a month, that it's really important. And I can do this with a straight face, that it's really important that they get familiar with what their testicles feel like. So if there's anything that comes up, then they don't need to put it off because this could be really bad, and they don't need to waver in telling their parent. And mom's sitting there going, usually shaking their head, But if it's dad at first is embarrassed, but then he's like going, you're right, son. If there's anything, we need to know about it immediately. So, and this is an immediate referral. You can't be you can't be bashful with adolescents, especially adolescent males, because it could save their life, also save their testicles and their potential of having children down the road. So another condition we see is phimosis and paraphimosis. Sometimes the foreskin is too tight to be retracted over the glans penis. Do not ever force a foreskin. Sometimes as newborns, it won't come. So as long as you can see the urethra opening, don't get too bent out of shape about it. We have it's kind of like anti-vaxxers and vaxxers. We've got circumcisers and non-circumcisers, and both groups have got their reasons for doing which. And if you've got your non-circumcisers, and that's fine, but then we've got to teach them how to care for this and what to look for. So physiologic or primary phimosis occurs over the first 6 years of life, okay? Pathologic or secondary occurs when the foreskin has previously been able to be retracted and is now unable, or it's after puberty and they're having issues. Okay. So something's going on. In fact, I've had a baby that was less of a mom who's an anti-vaxxer as well as an anti-circ. Um, he had an infection inside the foreskin before he was 2 months old. Go figure, right? But I couldn't, I couldn't pull the foreskin back. It wouldn't go that far. So, but it was red and swollen. And anyway, but we treated it with Bactrim and it cleared up and he hasn't any more problems. Now, paraphimosis is a retracted foreskin that cannot be reduced to normal. And this is very painful because it can constrict around the urethral opening, especially if it's really tight. If it can't be retracted over the head of the penis, then it can put a lot of pressure. They can't pee, they're in pain. This can be emergent. So balanitis, inflammation of the glands, and that's what I was actually talking about a while ago. My little one who got infection inside the foreskin was balanitis, and I'm not going to pronounce the next word. Is inflammation of the foreskin and the glands occurring in males with phimosis, so you can't retract it. Secondary secretory glands around the corona. So, and you'll get parents that get freaked out about this. Okay, if parents on circumcised babies aren't making sure that they're retracting that skin back with each diaper change and making sure, because new skin can stick back to itself. So a lot of times these babies will come in, if mamas haven't had a boy before, if they haven't been around this, and they're scared to death to pull that foreskin all the way down so it exposes the corona, that skin will stick back to itself up around the edge of the corona, and then they'll get white little like curds that you may see an edge of or up through the skin, and parents are freaking out. So I have to reduce that. I have to pull that foreskin back, and then we clean it out, and I have to explain about that white fluid, because there are glands around the base of the corona that secrete that for lubrication. Okay, so this can occur with phimosis. Poor hygiene can be involved, or it can just be, especially with little ones like this, it's just where mama hasn't pulled or daddy hasn't pulled the foreskin back, and it just kind of, and it's stuck, and the sebum just coagulates under there. I don't know how else to explain it. When you see it, you will understand it. If this is an older kid, like an adolescent, we need to consider that there's a possible STI. If there is drainage, you need to culture it. And we're going to give antibiotics appropriate to cover for skin and staph. Okay, so we've got some different conditions here. So this looks like some balanitis. We have a non-circ baby that has inflammation and redness. So this is more down here at the bottom. See the redness on the picture on this side, on that is right, left. You're right, or with the gloved hand, and that's just really red. Although it doesn't look like we have phimosis or paraphimosis, but we may have some infection going on, and we may not be able to retract that beyond. Now, that is a very tight, very, very tight foreskin, but that's on the little baby. So, but then we've got a really good picture of an inflamed balanitis down here at the bottom. So this is significant. Testicular torsion is a twisting of the spermatic cord, and it is a emergent situation. There is a 6-hour window before ischemic damage occurs, and this can be caused by activity, trauma, and sometimes just even standing up. It's usually uncommon prior to 10 years of age. So as boys are hitting their puberty, sometimes early puberty, this can hit. Some of the signs and symptoms are sudden, intense scrotal pain. Do not ever ignore that. Nausea, vomiting, possibly history of bouts of pain that come and go, which means it twists and then it goes back, and it twists and it goes back. Most of the time they don't have a fever with this. You're going to do a urinalysis, and it's usually normal, but you're also going to do a ultrasound, and they're going to look at testicular blood flow, sometimes with a Doppler. I've had, in the last 2 years, I guess I've had incidents with this. It would come and go with this kid, but he was walking like John Wayne, he was walking like a cowboy who'd been ridden in a saddle too long. And it was a while before he told his mama that he was having issues. And of course, he didn't have a fever, but you would touch his scrotal area and he absolutely would come off the table, and it was swollen. He was embarrassed to death to have me see him, but that's who he had. And I knew he was coming in, so I had ultrasound on standby because we didn't have ultrasound at the office where I was seeing him. So we had ultrasound on standby, and I had found out who the urologist was on call and had that number ready to go. So if we thought that that's what was going on, we were going to immediately send him to ultrasound and call the urologist. And after I saw him, we ultrasounded him. They weren't sure. It was iffy. They pretty sure it wasn't testicular torsion, but there was definitely something going on. The urologist saw him in office. They did the Doppler part in the office to look for blood flow. They actually put him on observation for a while at the hospital, and they did some more. They did some more radiographic studies. Come to find out that he had a there's a little appendix of the testes, and that's what was twisted. And so they had to go in and fix that. It was of course, it was a laparoscopic kind of thing. But once they did that, he was good. And I will have to remark about this urologist actually came and visited this child at his home to make sure that he was still doing okay. And that was before COVID. So I was really impressed with that. And it was not necessarily a friend of theirs or anything like that, but it was just impressive that that urologist went to that length to make sure that that kid was okay. So just because it doesn't fit the scenario, any scrotal pain or swelling needs immediate evaluation. Okay, that's all I've got for urology or genitourinary. There's a lot of other things that we could have talked about. And again, if you have any questions about that, and I'm sure you will, don't be afraid to get them to Dr. Blankenship and we'll get the answer. So I'll see you guys in a little bit. Oh, whoa, wait a minute.
We're not stopping.
Oh, you're not stopping?
No, keep going.
Now, you should also see this somewhere in your stuff. This is a great sheet on how to determine glomerulonephritis, chronic glomerulonephritis, nephrotic syndrome, ATN, which is acute tubular necrosis, and vice versa, and some of the lab work that you should be doing, what you should see. And if Dr. Blankenship doesn't have that up, she will get it up. So, see ya.